We were called to a 63-year-old male complaining of central chest pain. We arrived on scene to find the individual laying in bed, notably clammy and fatigued above that of his normal presentation, according to relatives. When questioned, the patient states that he suffers from angina, but he normally self-administers a spray of GTN and the pain will go away once he lies down. He says that today he has come home from work, sat down to watch some TV, and the pain had gotten progressively worse. He had taken 2 sprays of GTN prior to QAS arrival to no effect, and states the pain is getting worse even after he has been lying down. He describes the pain to be 8 out of 10 non-radiating central crushing chest pain. The patient was tachycardic, hypertensive, with a 12-lead ECG revealing a sinus tachycardic rhythm with no obvious ST elevation present. Patient has a history of type 2 diabetes, high cholesterol, high blood pressure, and a history of angina for which he is all medicated for. From the presented information and patient presentation, the pain cannot be ruled out as cardiac, and therefore due to knowledge obtained through CSB 332, I was able to assist in treatment for this patient. This included administering a further 300 mg aspirin tablet and additional sprays of GTN. Along with both of these administrations, it was important to double-check indications and contraindications for both drugs despite the patient already being prescribed both medications. This involved monitoring the patient's vital signs to make sure they were within normal limits for GTN administration, questioning the patient about the concurrent use of erectile dysfunction medication, looking for signs of head trauma, and ruling out a CVA. For aspirin administration, it was important to make sure that chest pain was not associated with a psychostimulant overdose. Due to my limited knowledge and clinical skills in cannulation and IV administration, as well as not being allowed to administer fentanyl, my mentors administered pain relief for this patient. Due to information gathered from this patient and the patient's assessment, it could be likely that this event is known as an unstable angina. This diagnosis comes from his history of having angina. However, this event, unlike his others, has come on at rest and has not been alleviated by his normal at-home management. Unstable angina is defined by Medline Plus as a condition in which your heart doesn't get enough blood flow and oxygen, having the potential to lead to an MI. Atherosclerosis can be a leading cause of unstable angina, as outlined in the Understanding Pathophysiology textbook 2011. Injury to the arterial wall endothelium caused by various functions, including hypertension, can lead to the rupturing of soft plaque. This soft plaque rupture provides a surface that promotes platelet adhesion and fibrin clot formation, otherwise known as thrombus. In many cases, it is the formation of the embolus which occurs when part of the thrombus breaks off and subsequently travels downstream and lodges into a smaller diameter vessel, blocking perfusion to the organ. If this occurs in the heart, it can have severe adverse effects for individuals, otherwise known as ischemic heart disease, caused by insufficient blood flow. Insufficient blood supply for less than 20 minutes has the likely outcome of angina. An unstable angina occurs when the thrombus is insecure, allowing reperfusion prior to necrosis. Risk factors that aid this process are hypertension due to the consistent elevation of systemic arterial blood pressure, which causes endothelial cell injury, as well as high cholesterol, which deposits cholesterol at endothelial cells. These cells cannot break down the cholesterol, causing excess cholesterol accumulation. With the patient having a history of both high cholesterol and high blood pressure, it increases his risk of heart disease if not adequately treated. Through attending this case and other cases similar in presentation, it has helped me to identify the importance obtaining patient history can be for treatment options. Patient history, allergies, and medication can play a detrimental role in the pre-hospital administration and treatment process. It is the ability to affect drug administration as well as withholding treatment options. The patient history obtained in the pre-hospital setting is predominantly retrieved by the collection of information in accordance to the SAMPLE acronym as outlined by the Manual of Clinical Paramedic Procedures. Information, however, can come from a variety of sources such as the patient themselves, relatives, carers, significant others, and even witnesses in the event of an accident as outlined by the Emergency and Trauma Care textbook by Curtis and Ramsden. Similar to how the case was dealt with in this particular individual, it is important to gauge treatment options based on patient presentation as well as clinical findings. Unless contraindicated against, aspirin administration should not be overlooked. It is stated by Joseph Hung in the Medical Journal of Australia that there is little risk in aspirin administration, but potentially great benefit. For me, reading into the benefits of aspirin in the pre-hospital setting have allowed me to identify and recognize that during clinical practice, if an AMI is even vaguely suspected, administering aspirin is likely to do more for the individual in the off chance that they are suffering from an AMI than if aspirin was withheld. This information has the ability to assist my future clinical judgment and recognise the importance of ruling out cardiac causes.